Sequential Organ Failure Assessment, SOFA, score, clinical application in multi-organ dysfunction. Multi-organ dysfunction syndrome, MODS, complicates up to 45% of septic ICU admissions and drives greater than 30% of in-hospital mortality worldwide. The SOFA score quantifies organ-specific derangements by integrating PaO₂/FiO₂, platelet count, bilirubin, MAP/vasopressor use, Glasgow Coma Scale, and creatinine/urine output, providing a reproducible metric for prognosis and therapeutic decision-making. Accurate calculation requires arterial blood gas analysis, complete blood count, liver function tests, and hemodynamic monitoring within the first 24 hours of ICU admission. Early goal-directed therapy, including 30 ml/kg superscript 1 crystalloid bolus, broad-spectrum antibiotics, and norepinephrine titrated to MAP greater than or equal to 65 mmHg, remains the cornerstone of management, with serial SOFA trends guiding escalation to renal replacement therapy or extracorporeal membrane oxygenation. Key points. Note, a SOFA score greater than or equal to 2 points within the first 24 hours predicts sepsis with a sensitivity of 88% and specificity of 73%, Sepsis 3, 2016. Each 2-point increase in SOFA is associated with a 20% rise in ICU mortality, adjusted or 1.20, 95% CI 1.15 1.26. A PaO₂/FiO₂ less than or equal to 100 mmHg, score equals 4, corresponds to severe acute respiratory distress syndrome, ARDS, with an in-hospital mortality of 46%, lung safe, 2018. Platelet count 20 times 10L superscript 1, score equals 4, occurs in 12% of septic shock patients and predicts bleeding complications in 18% of those cases. Total bilirubin greater than or equal to 12 mg per deciliter, score equals 4, is seen in 9% of MODS patients and confers a 30-day mortality of 41%. MAP less than 70 mmHg despite greater than or equal to 0.1 g/kg superscript 1 min superscript 1 norepinephrine, score equals 2, occurs in 27% of septic shock and mandates vasopressor escalation. Glasgow Coma Scale less than or equal to 8, score equals 4, is present in 22% of MODS cohorts and predicts need for airway protection in 100% of those cases. Creatinine greater than or equal to 5.0 mg per deciliter or urine output less than 0.5 ml/kg superscript 1 H superscript 1, score equals 4, develops in 15% of septic patients and signals initiation of renal replacement therapy in 68% of affected individuals. A SOFA greater than or equal to 2 points over 48 hours after ICU admission increases the odds of death by 1.5-fold, p less than 0.001. Implementation of the Surviving Sepsis Campaign 2021 bundle reduces 28-day mortality from 38% to 31%, RR 0.82, 95% CI 0.77 0.87. Early norepinephrine at 0.05 g/kg superscript 1 min superscript 1, titrated by 0.02 0.05 g/kg superscript 1 min superscript 1 every 5 minutes, achieves target MAP greater than or equal to 65 mmHg in 84% of patients within 30 minutes. Cross-vasopressin trial, 2022. Continuous renal replacement therapy, CRRT, initiated at a dose of 25 ml/kg superscript 1 H superscript 1 reduces SOFA renal subscore progression by 1.2 points versus intermittent hemodialysis, p equals 0.03. Overview and epidemiology. The Sequential Organ Failure Assessment, SOFA, score is a bedside tool that quantifies the extent of organ dysfunction in critically ill patients, primarily those with sepsis, trauma, or postoperative complications. It is codified under ICD-10 code R65.20, severe sepsis with organ dysfunction, and R65.21, severe sepsis without septic shock. Global incidence of sepsis-related MODS is estimated at 19.4 million cases per year, representing 31% of all ICU admissions, World Health Organization, 2022. In high-income regions, the incidence is 27 cases per 100,000 population, whereas low- and middle-income countries report 45 cases per 100,000, ICU Global Registry, 2021. Age distribution peaks at 68 years, median, with a male predominance of 57%, sepsis 3 cohort. Racial disparities are evident. African American patients experience a 1.4-fold higher risk of MODS compared with Caucasians after adjusting for comorbidities, NANS, 2020. Economically, MODS contributes an estimated $24 billion in direct hospital costs annually in the United States alone, driven by prolonged ICU stays, median 12 days versus 4 days for non-MODS patients, and high utilization of organ support technologies. Modifiable risk factors include delayed antimicrobial therapy, 1H after recognition, which raises 30-day mortality by 12%, HR 1.12, 95% CI 1.08 1.16, and excessive crystalloid administration, 4L in the first 6H, associated with a 9% increase in pulmonary edema incidence. Non-modifiable factors comprise age greater than 80 years, RR 1.35, chronic liver disease, RR 1.28, and genetic polymorphisms in TLR4, ASP299GLY, that confer a 1.6-fold higher susceptibility to septic organ failure, meta-analysis, 2021. Pathophysiology. MODS arises from a dysregulated host response to infection, trauma, or ischemia, culminating in cellular bioenergetic failure, endothelial activation, and microvascular thrombosis. At the molecular level, pathogen-associated molecular patterns, PAMPs, engage toll-like receptors, TLR2, TLR4, triggering MyD88-dependent NF-kappa B activation. This upregulates pro-inflammatory cytokines, IL-6, TNF-alpha, with median peak concentrations of 135 pg/mL⁻1 and 210 pg/mL⁻1 respectively in septic shock. PaO₂, 2019. Simultaneously, anti-inflammatory mediators, IL-10, rise to 78 pg/mL⁻1, creating a cytokine storm that impairs mitochondrial oxidative phosphorylation, evidenced by a 30% reduction in ATP-ADP ratio within 12H of insult, murine CLP model, 2020. Endothelial glycocalyx shedding, quantified by plasma syndecan-1 levels greater than 150 ing/mL⁻1, occurs in 62% of patients with a SOFA respiratory subscore greater than or equal to 3 and predicts capillary leak with a 1.9-fold increased risk of pulmonary edema. Complement activation, C5a, amplifies neutrophil extracellular trap, NET, formation, leading to disseminated intravascular coagulation, DIC, in 18% of MODS cases. DIC score greater than or equal to 5 correlates with a SOFA increase of 2 points, P less than 0.001. Key points: respiratory, alveolar epithelial injury mediated by surfactant protein D, SPD, depletion, resulting in a PaO₂/FiO₂ decline to less than 200 mm of mercury within 24H in 41% of patients. Renal, tubular cell apoptosis driven by high mobility group box1, hMGB1, concentrations greater than 10 ing/mL⁻1, leading to creatinine rise greater than 2 mg per deciliter in 27% of septic patients. Hepatic, Kupffer cell activation releases nitric oxide, causing cholestasis. Bilirubin greater than 6 mg per deciliter appears in 22% of MODS cohorts. Neurologic, blood-brain barrier permeability increases, measured by CSF albumin quotient 9, contributing to encephalopathy with GCS less than or equal to 13 in 35% of cases. Clinical presentation. Patients with evolving MODS typically present within 48H of a precipitating insult. The most frequent clinical features include, atypical presentations are common in the elderly, greater than 80Y, and immunocompromised hosts. 41% of elderly patients lack fever, and 33% of diabetics present with silent hypoperfusion, lactate greater than or equal to 2 millimoles per liter without overt hypotension. Physical examination findings such as cool extremities have a sensitivity of 0.62 for shock, while mottled skin carries a specificity of 0.84 for impending circulatory collapse. Key points: hypotension, MAP less than 65 mm of mercury, in 68%, sensitivity 0.71, specificity 0.64. Altered mental status, GCS less than or equal to 13, in 35%, sensitivity 0.68. Oliguria, urine output less than 0.5 milliliters kg superscript 1H superscript 1, in 27%, specificity 0.79. Jaundice, bilirubin greater than 2 mg per deciliter, in 22%, sensitivity 0.55. Diagnosis. The diagnostic workflow for MODS centers on systematic organ assessment within the first 24h of ICU admission. 1. Arterial blood gas, ABG obtain PaO₂/FiO₂ ratio, reference range 300500 mmHg. A ratio less than or equal to 400 scores 1 point, less than or equal to 300 scores 2, less than or equal to 200 scores 3, less than or equal to 100 scores 4. 2. Complete blood count, CBC platelet count reference 150400 times 10 L superscript 1. Scores, 150100 equals 1, 10050 equals 2, 5020 equals 3, less than 20 equals 4. 3. Liver function tests, LFT's total bilirubin reference 0.11.2 mg/dl. Scores, 1.22 equals 1, 26 equals 2, 612 equals 3, greater than 12 equals 4. 4. Hemodynamics, MAP measured via arterial line, if MAP greater than or equal to 70 mm of mercury without vasopressors, score equals 0. MAP less than 70 mm of mercury or use of norepinephrine greater than or equal to 0.1 g kg superscript 1 min superscript 1 scores 1. Higher doses up to 0.2 g kg superscript 1 min superscript 1 score 2, 0.2 0.3 g kg superscript 1 min superscript 1 score 3, greater than 0.3 g kg superscript 1 min superscript 1 score 4. 5. Neurologic, Glasgow Coma Scale, GCS, reference 153. Scores, 1314 equals 1, 1012 equals 2, 69 equals 3, less than or equal to 5 is equal to 4. 6 is renal, serum creatinine reference 0.61.2 mg/dl, urine output reference greater than or equal to 0.5 milliliters kg superscript 1H superscript 1. Scores, creatinine 1.22 equals 1, 3.5 equals 2, 3.55 equals 3, 5 is equal to 4, urine output less than 0.5 milliliters kg superscript 1H superscript 1 scores 1, less than 0.3 milliliters kg superscript 1H superscript 1 scores 2, less than 0.1 milliliters kg superscript 1H superscript 1 scores 3, anuric equals 4. Key points, chest CT, preferred for ARDS evaluation, bilateral ground glass opacities with consolidation in greater than 80% of patients with respiratory SOFA greater than or equal to 3. Renal ultrasound, detects obstructive uropathy, sensitivity 0.85 for acute tubular necrosis when combined with Doppler resistive index greater than 0.8. Sepsis 3 definition, infection plus SOFA increase greater than or equal to 2, sensitivity 0.88, specificity 0.73. HU-SOFA, respiratory rate greater than or equal to 22 per minute, altered mentation, systolic BP less than or equal to 100 mm of mercury, each 1 point, greater than or equal to 2 predict sepsis with LR equals 3.2. References. 1. Huang N et al. Efficacy and safety of PaO₂ decoction for sepsis, a randomized controlled trial. Phytomedicine, International Journal of Phytotherapy and Phytopharmacology. 2025, 136:156311. PMID, 3965360, https://pubmed.ncbi.nlm.nih.gov/3965360. DOI 10.1016/J.Find.2024.156311. 2. Di Raimondo d et al. Non-coding RNA networks as potential novel biomarker and therapeutic target for sepsis and sepsis-related multi-organ failure. Diagnostics, Basel, Switzerland. 2022, 12-6. PMID, 357411168, https://pubmed.ncbi.nlm.nih.gov/357411168. DOI 10.3390/diagnostics 12061355. 3. Prepeliak CS et al. The involvement of endothelin-1 in sepsis and organ dysfunction, a novel biomarker in patient assessment. Biomedicines. 2025, 13-10. PMID 4115363, https://pubmed.ncbi.nlm.nih.gov/4115363. DOI 10.3390/biomedicines 13102480. 4. Ferrari F et al. Clinical applications of polymyxin B hemodsorption in sepsis and septic shock. Journal of Intensive Care Medicine. 2026, 41, 291-96. PMID 408888647, https://pubmed.ncbi.nlm.nih.gov/408888647. DOI 10.1177/08850666251368803. 5. Yayapur F et al. The effects of L-carnitine supplementation on inflammatory markers, clinical status, and 28 days mortality in critically ill patients, a double-blind, randomized, placebo-controlled trial. Clinical Nutrition ESPN. 2022, 49:61-67. PMID 356238669, https://pubmed.ncbi.nlm.nih.gov/356238669. DOI 10.1016/J.Cliness.2022.04.001. 6. Lisi et al. The association between coagulation function and prognosis in patients with sepsis, a meta-analysis of predictive performance. Introduction. Frontiers in Medicine. 2025, 12:17068082. PMID 414888071, https://pubmed.ncbi.nlm.nih.gov/414888071. DOI 10.3389/med.2025.17068082. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.